Welcome to PGOG postgraduate class in Obstetrics and Gynecology, and today's topic is screening for cervical cancer, current recommendations. Why cervical cancer screening is a success story as opposed to the screening for ovarian cancer. These two are the common genital malignancies, and still there is so much of a contrast between the screening success of cervical malignancy and ovarian malignancy. And the various reasons are cervical cancer has a precancerous condition, whereas ovarian cancer unfortunately has no precancerous condition, except rare cases of endometriosis, which do go for endometrioid or clear cell carcinoma, and that too in very few cases. Secondly, this precancerous lesion of the cervix remains for many years as it is and gradually progresses to the invasive cancer. So we have a chance of catching it in those years, treating it, and completely preventing the invasive cancer. And this is not applicable for ovarian cancer. Cervix is easily accessible whereas ovaries are deep seated into the peritoneal cavity. Treatment of precancerous lesions completely eliminates the invasive cancer for cervix, whereas it is not so with the ovarian. And whenever regular screening programs are available, then there is so much of high sensitivity of this regular screening that there is a drastic reduction in the number of cases. Whereas on the other hand, though, if we try to do the screening test for ovarian cancer, and that too on a yearly basis, still the sensitivity or ability to catch the true positives, that still to rule out the true negatives, that is a sensitivity that still remains low with the ovarian cancer. That means even if we go for CA-125 annually or ultrasonography annually, still it fails to lead to the reduction in the rate of ovarian cancers. Role of gynecologist is well defined as far as this screening for cervical cancer goes. We need to make aware our non-gynec medico friends about the importance of cervical cancer screening. We should be doing testing of our family and friends aggressively. One has to do maximum opportunistic screening as a gynecologist. That means whenever a patient comes to us, whatever may be her complaint or presentation, whenever she is in the age group where the screening is recommended, we should grab the opportunity and do the screening. That is opportunistic screening. We should be the part of public awareness programs, and we should make the public aware of the fact that cancer cervix is a preventable disease. Aim of screening of this cervical cancer is to catch the disease in precursor state. Though few cases of early diagnosis of cervical cancer can also be achieved, especially the cancer which is not visible to the naked eye might be detected with these screening methods. But the main aim is to catch the disease in precursor state, and pre-malignant state is called as cervical intraepithelial neoplasia. Treatment of CIN prevents cancer, invasive cancer, and the main aim is to reduce the number of cases of CA cervix as well as to reduce the deaths because of the cancer cervix, and both of these are achievable with following us strictly to the recommended screening program. Screening tests can be divided in three categories: molecular test, cytologic test, and visual inspection. Nuclear acid amplification test, that is a technique, that is a technique which is used to detect the high-risk HPV DNA strains. Available screening tests for cervical cancer are: first is called as primary HPV testing. Now, what do you mean by primary is whenever a HPV test is done without concomitant use of the cervical cytology, that is standalone test. That means we are using HPV test as only single test for screening. Then the terminology which is given by American Cancer Society 2020 guideline for such a test is primary HPV testing. So we need to be very careful while using the terminology. Whenever we mean that only single test is being used as HPV DNA test for cervical screening, the terminology which we need you to be using is a primary HPV testing. Latest guideline which is available at present for this screening program is American Cancer Society 2020 guideline, and that guideline has given this terminology. If we combine the HPV testing with the cervical cytology, then it is called as co-testing. US FDA, that is Food Drug Administration, it has approved only two test kits to do the primary HPV testing, whereas all the other test kits, they are being used for co-testing. That means whenever these other test kits are being used for HPV testing, one has to use it along with doing a cervical cytology. So at present only two tests have been approved as tests where the HPV testing can be done as standalone test or primary HPV testing. Third is cervical cytology, which is being done since decades and still remains the primary way of screening for cervical cancer in many parts of the world, especially for the low resource settings situations or healthcare sector. Cervical cytology still is at the top as a test for cervical cancer screening, in which it can be done two ways: by liquid based cytology, which is better as compared to second, that is conventional PAPS test. Now we call it as a PAP test. The long form is Papanicolaou's test. Papanicolaou was the first person who gave us the technique of using the stain and looking at the cell morphology, and that is why the name which is given to the test is PAP test. Now, even for cervical cytology, for HPV testing, we do need facilities, and test is not widely still available in many parts of the world, including India, as well as it is expensive also. But even with cervical cytology also, what we need is a person who will be correctly collecting the sample, as well as what is more important is we need a trained cytologist who can give us reliable results. So that is the drawback, or one can say that is at present the disadvantage of these tests. And to overcome that, we have the test for low resource setting, which is called as VIA. VIA is visual inspection after application of acetic acid, or secondly, we can use Lugol's iodine and inspect the cervix, that is called as visual inspection after application of Lugol's iodine with a short form as VILI. There are two ways the sample can be collected. Either it can be collected by a healthcare provider, which is called as provider collection. The way of collecting the sample as provider collection. Other is by the woman herself, then it is called as self-collection. In recent years, there are many studies which have compared this self-collection versus provider collection for various tests. As we know, the sample collection is same for cytology as well as for HPV testing. But it has been seen that the results of the HPV testing are equal whether it is a self-collection or provider collection. So self-collection is equally effective, and so it can be promoted whenever we want to do the HPV testing, whether it is primary test or co-test. But for cytology, it has been seen that the quality of the smear gets affected if it is a self-collection, and that is why for cervical cytology, provider collection is better than self-collection. This is just a revision. We all know about transformation zone from our undergraduate years. But whenever we are doing a screening for cervical cancer and collecting the sample, what we are collecting is mainly the cells from this transformation zone. So what is transformation zone? Before puberty, this is the columnar epithelium lining the endocervical canal, and this is the squamous epithelium lining the ectocervix, and squamo-columnar junction is just at the level of the external os. After puberty, with a hyperestrogenic state, and whenever in reproductive life also there is an increase in estrogen, what is happening, such as with pregnancy or with the use of OC pills, what happens is there is more of a hyperplasia of the columnar epithelium that leads to the shifting of squamo-columnar junction away from the external os. So this becomes the original squamo-columnar junction, which is there in the reproductive age group, not at the external os, at the level of external os, but it is on the ectocervix away from the external os. So this is the original squamo-columnar junction. But there are reserve cells which are present and which are continuously leading to metaplasia from columnar to squamous. So the blue area is where there is a presence of squamous metaplasia with islands of columnar cells. So there will be a mixture of columnar and squamous cells depending on how much is the level of squamous metaplasia. And this new squamo-columnar junction will be near the external os, which is so that older one is said to be caudal and newer one is typically described as at a cranial end on the ectocervix. And the area between these two squamo-columnar junctions, new and old, is called as transformation zone. This is a cut section where we can identify it in a better way or understand it in a better way. That black is the external os and just surrounding the external os are the columnar cells or the endocervix. Then we have blue cells, that is where transformation zone is present between the new squamo-columnar junction, which is nearer the os, and the old squamo-columnar junction, which was away from the os. And this yellowish area is the squamous epithelium of the ectocervix. So blue is the transformation zone. What is happening? What is the importance of transformation zone? Is there is maximum cellular unrest is present because the reserve cells are continuously going for metaplasia. These cells which are changing from columnar to the squamous epithelium, these are more prone to go for get infected with the HPV. Human papillomavirus virus infection is more with this cellular unrest, and that leads to the onset of cervical intraepithelial neoplasia. And if neoplasia remains persistent and untreated, it can lead to the development of carcinoma cervix. This is Ayre spatula. We all know the flat end is there, and another end with an elongated projection is there, and this elongated end is introduced into the external os, and this Ayre spatula is rotated by 360 degrees 2 to 3 times, and that is how we get the sample of exfoliative cytology whenever we are doing the conventional pap test. So cervical cytology, there are two ways or two methods of doing cervical cytology. One is conventional pap test and other is a liquid based cytology. This other flat end is used usually, it was used to collect the lateral vaginal wall smear for hormonal studies. Technique of pap test, you all must be doing it on a daily basis. It is just a revision. It is better that patient has abstinence for 48 hours. No lubricants are to be used on the speculum. Better to use a cusco self-retaining speculum than sim speculum for better visualization and exposure of the cervix. We should be scraping the transformation zone by elongated end of the Ayre spatula. We should be rotating it by 360 degrees 2 to 3 times to get the maximum cellular yield. Then this sample is to be spread over the glass slide. This slide needs to be fixed in a fixative which contains ethyl alcohol. 95% of ethyl alcohol fixative is used, and the slide should be kept for at least 30 minutes for fixation. We should always be using endocervical brush or moist cotton tip applicator for endocervical smear, and it should be spread on the same slide, preferably on the same slide, or on the separate slide. Now this last part is important, which I think many of us we do fail to take separate sample from endocervical canal, and it is necessary to take a separate sample because sometimes the cellular pathology might be only limited to endocervix and may not be on the transformation zone, and that is the reason why this pap smear should always be uh, including the squamocolumnar junction, that is transformation zone smear, as well as endocervical smear, which can be obtained either with a endocervical cytobrush like this, or one can use a moist cotton tip applicator for that. For liquid-based cytology, cytobrush is used. As we can see here, this is a disposable cytobrush, and it has elongated end which is introduced into the endocervical canal, and we get an endocervical cell sample from here. And as with the Ayre spatula, there is a end here, broad end, which will be scraping the transformation zone. So there is no need of using a separate endocervical brush whenever this disposable cytobrush is used. It comes as a kit along with the liquid medium whenever we go for liquid-based cytology. Now, after rotating it 2-3 times, one needs to rinse it vigorously into the liquid medium. And some of the companies are providing it where it can be detached also, so that the detached end remains with the liquid medium and it is sent to the laboratory. This liquid medium is centrifuged and the cells are separated, so that whatever is debris is separated from the cells. These cells are spread evenly on the slide, and as we can imagine, there will be less clustering and overlap of cells as compared to the conventional pap test. That is a main advantage, and that is why liquid-based cytology has better diagnostic accuracy than pap test, because in pap test, because of the clumping and clustering, some of the cell morphology will be hidden because of the overlap of the cells, which is not so with liquid-based cytology. Another advantage is computerized automated screening is possible whenever we are using this evenly spread liquid-based cytology smear. So that what happens is this computer itself separates the slides between normal and those which need to be seen by a cytologist. This drastically reduces the work burden of the cytologist, so that normal are getting separated by computer itself. And whenever there is a possibility of abnormal cellular morphology, these slides are only to be seen by the cytologist. This facility is now available at many of the large centers, even in India. This same separated cell sample can also be used for HPV testing. So whenever we want to do co-testing, then we can do liquid-based cytology. Same sample can be sent for HPV testing, or even if we want to do primary testing, we can use the same method and send the sample for HPV testing. Visual inspection after application of acetic acid, where what is used is a 3% acetic acid. Acetic acid, its action is it coagulates nuclear proteins. And whenever the cells have high nuclear proteins, that area turns white in color. So whenever there is a acito-white area, that means the cells in that area have increased nuclear proteins. Whenever there is a cervical intraepithelial neoplasia, then the nuclear proteins are more, and that is how acito-white areas are suggestive of CIN. But unfortunately, even with inflammation, leukoplakia, cervical condyloma, also there is increase in nuclear protein, and these other conditions are also associated with development of acito-white area, and that is why VIA has a less specificity. Same goes with Vili, where Lugol's iodine turns brown with glycogen in the cells, and in abnormal cells or proliferating cells, the glycogen level is less, and that is why that area remains pale or yellow in color as seen here. But here for Vili also, same differential diagnosis is there as for VIA. There is now we know beyond doubt that the cause of carcinoma cervix is infection with human papilloma virus infection. So we should know something about the virus and this viral infection. It is this HPV is a DNA virus and it leads to the development of asymptomatic infections. Presently, there are more than 100 and up to 200 subtypes which have been identified. This HPV uh, virus, it has more than hundreds or up to 200 subtypes which are being which have been identified till date. And these HPV, various subtypes of HPV, they infect cervix, vagina, vulva, penis, anus, mouth, tonsil, throat. So all these tissues are getting affected with the infection, and there is a risk of malignancy in all these tissues, and that is the reason why this HPV vaccine is recommended not only for girls but also for boys. Out of these 100 to 200 subtypes, about 30 subtypes infect lower genital tract in females. Out of these 30, about 15 subtypes are high risk causing cervical cancer. With these high risk strains, if the infection remains persistent, it might lead to cervical intraepithelial neoplasia, and if cervical intraepithelial neoplasia remains persistent and untreated, then that patient can have invasive cervical cancer. HPV 16 and HPV 18 are found in 70% of cervical cancers, whereas HPV 6 and 11 are responsible for development of benign conditions such as genital warts and laryngeal papillomatosis. 99% of cervical cancers are because of HPV infection, or in 99% of the cancer tissues, HPV is detected. HPV infection leads to both squamous as well as adenomatous type of cervical cancer. 90% of the HPV infection resolves spontaneously by 2 years. So remaining 10% remain persistent. They might go for CIN. CIN also sometimes resolves, but in few cases it remains persistent and ultimately gets converted into the invasive carcinoma. There is something which is called as HR-HPV, that is high risk HPV infection. So highest risk, we already know 16, 18, but highest risk is also with 31 and 45, whereas high risk, other high risk strains are 33, 35, 39, 51, 52, 56, 58, 59, and 66, 68. Probably high risk are also there, 26, 53, 73, 82. So many are there. HPV vaccine, they protect either against 2 subtypes, that is bivalent, 4 that is quadrivalent, or 9 that is nonavalent. Example of bivalent is Cervarix, which protects against 16-18, whereas Gardasil is quadrivalent, which is protecting in addition to 16-18, 6 and 11, protecting against genital warts and laryngeal papillomatosis. On the other hand, Gardasil 9 is the example of nonavalent, where 9 strains are against 9 strains, they provides the protection. Apart from 6, 11, 16, 18, 31, 33, 45, 52 and 58. So all highest risk are covered by this nonavalent, but still, as we can appreciate, there are so many high risks which are not covered by nonavalent also, and that is the reason why, irrespective of the vaccination, the screening should continue as it has been recommended. If you are asked why the screening is same for vaccinated and non-vaccinated, your answer should be the screening is same in vaccinated, as all subtypes are still not covered by the vaccines. Now, for postgraduates, you need to remember this at least highest risk and high risk. And how I have remembered is 16, 18 we all know are there. There are no strains in the 20s. In 30s, all odds are high risk except 37. So 31, 33, 35, 39. 45 is the number as we commonly use the age of menopause as 45. I have remembered like that. Maximum are in 50s, but So that 16, 18, same way we have 56, 58, 66, 68. And we have 51, 52, that is before 40, 35, 45, we have 51, 52, and there is 59 also. So maximum are in 50s and 66, 66, 68. So vertically we can remember 16, 18, 56, 58, 66, 68. Whereas 35, 45 are also there. All in 30s, all odds are higher except 37. That is how you need to devise your own way how you will remember. But you need to remember at least these many subtypes because these are high risk strains for development of cervical cancer. HPV vaccination is indicated for both men and women. It has maximum efficacy whenever it is given in a non-infected individual. That means before the onset of sexual activity, if it is used, then the efficacy is maximum. That is why the age which is recommended is 11 to 12 years. It can be started as early as 9 years also. If a person fails to get it by 11 to 12 years, it can be given up to 26 years also. Efficacy is good even if it is given up to 26 years. But the latest recommendation for nonavalent vaccine is it can be given up to 45 years, and it should be a shared decision between the healthcare provider and a patient. We should counsel the patient. The reason is even after 26 years also, new HPV infections do continue to occur throughout the reproductive life. And we know that CA cervix has a second peak after the age of 60, and by giving it late, we hope to take care of that second peak of cancer cervix cases. Coming to the accuracy of various screening tests in a table form, it becomes easier for us to compare. Now, these figures, what I have taken are the approximate high, what are the on an average, what have been given by various studies. So, if we use primary HPV testing, sensitivity as well as specificity is more than 90%, and it can be as high as 95 to 98% also. Conventional PAP test has a low sensitivity of 60% and specificity of 70%, whereas liquid-based cytology has better sensitivity and activity as well as specificity is around 80%. Co-testing, as we are using two tests, it gives us immediate risk for CIN3 by calculating the risk. So we can get the particular number as how much is the risk for that individual if we use the co-testing. Whereas, as you know, there is a low specificity as well as sensitivity for VIA and VILI because there are so many other conditions which can also produce the similar picture. This is important slide where comparatively we can at a glance see how the guidelines have changed over the years. Now, why there is so much of change and why this screening for cervical cancer is a dynamic field, why there is so much of change in the guideline. The reason is as the evidence emerges, the guideline changes. The main reason was for many decades we were banking only on cervical cytology as a screening test. But then there are these HPV DNA testing and HPV RNA testing became available to us, and that resulted in a major change in the guideline over the years. As the evidence started emerging, the guidelines also kept on changing. So we have ACS 2012, that is American Cancer Society 2012 guideline. Then we have this United States Preventive Services Task Force 2018 guideline, and latest one which we have at present is a American Cancer Society 2020 guideline. Previously, it was recommended that the screening should start at the age of 21, but ACS 2020 says that the screening should be started at the age of 25 years. This is the major change in the guideline. Secondly, up to the age of 30, previously what was recommended was only pap smear every 3 years by both the guidelines. But with the new guideline, after the age of 25, only one single test is preferred, that is primary HPV test, which should be done at the interval of 5 years. So the preferred test better test. If we compare these three tests, the best is primary HPV test, which has been recommended by ACS 2020, and it should be repeated every 5 years. If it is not available, we can go for co-testing every 5 years, which is acceptable. Even co-testing not available, we can go for pap smear every 3 years, which is also acceptable. So this is the latest guideline. Previously, up to the age of 30, pap smear was recommended, and then there was a recommendation for 2012 co-test every 3 years and pap test every 3 years. But then the evidence emerged, and it was realized that whenever we are using co-testing, it can be done every 5 years. But 2018 also gave the equal importance or weightage to all the three: pap every 3 years, or HPV primary every 5 years, or co-test every 5 years. That this has made change. The thinking has changed, and there is a major change where now at the top is the primary HPV testing, and then if it is not available, then only we go for co-testing or pap test. The screening ends at the age of 65 years as per all the three guidelines. So main changes are: screening starts at the age of 25 years, and primary HPV test is preferred over co-testing or even over pap test or cervical cytology. So why to start screening at 25 years? Why there is a change in the guideline? What is the rationale behind the change that has been given by the people who have designed the guideline? ACS concluded that screening at 21 to 24 years has more harm than benefit. HPV infection in this age group gets spontaneously resolved in the majority because immunity is good in this younger women. Unnecessary interventions add to the cost as well as medical caretakers' time. And what is equally important is, if unnecessary cone biopsies are done, that adversely affects the obstetric career of these young women also. In United States, majority of women in 21 to 24 years are presently vaccinated. They have already received HPV vaccine at the age of 11 to 12 years, and so they are protected against at least HPV 16 and 18. They have received bivalent vaccine, and that is why the need for the testing is less as compared to the previous generations. Why primary HPV test is preferred over co-test or pap test is, as we have already seen, pap has low sensitivity, only 60%. That means if we are doing 100 pap tests, around 40 have false possibility of having a false negative. So that much of a low sensitivity it has. If it is repeated, and it needs to be repeated every 3 years, more frequently as compared to HPV testing. But if we repeat it and if 3 pap tests are negative, then sensitivity is said to be 99%. But single pap test, it has only 60% sensitivity. It needs to be repeated more frequently as compared to HPV test. Co-test has less specificity, and unnecessary interventions are more with co-test as compared to primary test, and these are the reasons why primary HPV test is preferred over co-test or pap test. Now coming to the Indian scenario and Indian guidelines, there is a organization which is called as National Cancer Grid, NCG, and under this organization, umbrella organization, there are 180 cancer institutes are part of this National Cancer Grid, and it has provided us the resource stratified guideline in 2019. The meaning of this terminology, resource stratified, is as per the resources, the guideline has given specific changes, and for that they have identified three resource settings in India. One is essential or limited resources, which are usually at PSC, CHC level, where very limited resources are there, and the facilities are provided either by trained workers or by trained nurses. Whereas there are second level of resource setting is called as optimal or enhanced resources, which are still at PSC or community health center levels, But here there are facilities are better, and these are provided either by trained nurses or physicians. And third is high resources, which are either at district hospitals, tertiary care centers, or at private hospitals, which are where the facilities are provided by trained nurses and physicians. So how the guideline changes is, for limited and enhanced resources, this screening starts at 30, whereas for high resource it starts at 25. VI, that is visual inspection after application of acetic acid, is the option which is available at limited or essential services, where we can even go for see and treat in the same sitting, whereas HPV DNA is, testing is advocated at enhanced and high facilities. How much should be the frequency? At least 1 to 3 times in the lifetime VI is should to be done for those who are getting services from these PHCs with limited resources. That means once, at least once in the lifetime of a woman, if VI is done, that is also acceptable by this guideline. So that is also a daunting task, not very easy for each and every woman in a rural area, remote areas, to be covered by VI. And whenever, if HPV DNA testing is available, if two tests are negative, it can be repeated every 10 years. Whereas for high resources, it can be repeated by 5 years. So cytology is not in the picture because what they have given is cytology as second option. If HPV DNA is positive, then we should go for cytology. That is the current recommendation. But if we see the present scenario, at most of the tertiary care centers and most of the major hospitals, cervical cytology is the mainstay for the screening for cervical cancer in India, even till date. Thank you so much.